Hello, and welcome back to this episode of this Healthy Life podcast. I'm so excited for my guest today. I have Dr. Mary Pardee, and she is here to share her wisdom all about hormones, and there's a lot of misinformation out there, so it's great to get to the bottom of some of these things. She is a naturopathic doctor that trained at Pardee, and she specializes in preventative medicine and longevity and works with clients in person here in Los Angeles and also remotely. So Dr. Mary Pardee, thank you so much for being here today.
Thanks for having me.
Excited to have you on the podcast.
Yeah, me too. I'm really excited.
Awesome. So I'd love for you to start just with a brief intro about yourself and how you got into this space, and then we can dive deep into hormones.
Sure. Yeah. I got into the space because of my own health issues. And I've loved biology, chemistry, science in general my entire life. So there was a natural inclination. But I had gut issues growing up. And I know we're going to talk about that separately. But really had chronic constipation, bloating for most of my young adult life and childhood, and went to gastroenterologists and saw specialists and did all the tests and just didn't get relief. And so I ended up taking it into my own hands, being like, I've got to figure this out. And so I talk about my personal story, but I learned a lot through my own health journey. And now I really help people sift through what is the noise of the wellness industry and how many myths and, things that are out there, because I've tried them all. So I'm speaking from experience where I'm like, there's a lot of BS out there, and there's a lot of stuff that works too. And so just to start with the things that are really evidence-based and effective for people, and then we can always get creative in the process.
Absolutely. Awesome. So super excited to dive deep into hormones today. Yeah. I think this is another one, right? There's so much misinformation out there and what you should do and when you should start doing things or addressing things. And I don't feel like there's a lot of support for women out there. As we age, not a lot of doctors are there to support us through the different phases of our hormonal changes and things like that. So let's dive in just kind of with the basics at first. So, first we start with perimenopause before we get into menopause. So what's kind of the differences between the two? What's going on in your body, and what age do you usually start to notice some of those changes?
Yeah, great question. So semantics, in terms of what is perimenopause, it's everything that leads up to menopause. And menopause is one single day. So menopause is the 12-month anniversary of your last period. So it's when you've been without a period for 12 months. That is your day of menopause. And then everything after that is postmenopause. And so the symptoms that a woman experiences prior to menopause are called perimenopause. And it depends on the woman, but it can last up to 10 years before menopause.
Fun.
Yeah, exactly. Most women, are experiencing changes around their mid-40s, but we can experience more subtle changes earlier on. So even in your late 30s, sometimes women will experience like sleep changes, mild changes, before any like cycle changes begin.
Gotcha. And then, so what are the symptoms in perimenopause that you can be like, hey, maybe I'm starting to enter this phase? Like, what are some things to look out for that might be shifting in your body?
Yeah, the most commonly ones that we talk about that most people have probably heard of are going to be hot flashes, night sweats, vaginal dryness, very common as well. Some of the less talked about symptoms are going to be sleep changes. So waking up in the middle of the night, inability to maintain sleep, being really, really common, and tied to a lot of progesterone shifts that are going to happen. Mood changes, increase in irritability, depression can be a symptom as well. Joint pain, aches, even fatigue is a possible symptom. Body fat redistribution, which we can talk about, all potential symptoms.
I've heard of a strange one too that unfortunately I haven't experienced just yet, but I'm just waiting for it to happen. Itchy ears.
Itchy ears.
What is up with that?
That's a weird one.
What is going on there?
Yeah, hormonal shifts can cause some weird things. Itchy ears can be one of them. Itchy skin can just be another one as well. But yeah, less discussed.
So why do you get itchy ears? What's
going
on there? It's just some
idea.
random
Hormonal
thing that your body's going through and decides to torture you with itchy ears.
Yeah, as if the hot flashes are not enough.
Right? As if that whole other list of symptoms are not enough already, right?
Yeah, so, but estrogen plays a big role in the skin, and so I'm guessing that has to do with it.
So are there ways to track like when you might be entering into perimenopause? I know like hormonal testing is so finicky and all over the place, and depending on the day that you're doing the testing can like alter the results or like what's going on. So is there any way to kind of do some labs and be like, get a picture of maybe where you are in this transitional phase in your life, or is it just kind of whatever's going on with your body, you got to just track that.
When I do a lecture on this, I show the different phases. So before you're in perimenopause, you're in your reproductive years. And during the reproductive years, for most women, we'll have really regular cycles. And so you have this rhythmic pattern to your hormones that happens every month. In perimenopause, things go chaotic. So you have spikes, you have valleys, it's much more unpredictable. Cycles can get shorter at first, and then they can get longer the further you go through the transition. And because of that erratic nature of the hormones, testing is it's a really complex thing to do because you have no idea where you're at. But in terms of looking at where you're in the transition, sometimes we'll run FSH, so follicle stimulating hormone, and FSH above a 25 indicates that you're in that menopausal transition. And so the higher the FSH gets, the closer you are to the transition. But again, there's going to be fluctuations there as well. There's a lot of signs though. So like I said, cycles changing is probably one of the easiest things to track where, okay, yeah, my cycles are getting much longer. You know, I haven't had a period in 90 days. That's obviously a sign you're going through perimenopause.
Okay. And then, so you mentioned menopause is just the 1 year anniversary. It's literally just one day. And I think a lot of times people are just like, oh, I'm going through menopause. And so that's not really like the right terminology, right? You're really kind of just going through perimenopause until that event happens.
And then you're postmenopausal.
So what happens in our body once you're through menopause, right? Like after that day, like what kind of hormonal things are happening? What kind of symptoms are you experiencing after you've gone through it?
Yeah, so once you hit menopause, you basically see flat lines in your hormones. So estrogen and progesterone are very low, and you're not going to see fluctuations in them. They're not going to, because your ovaries have shut down. And so those are going to be the main changes where you're just seeing very low estrogen and progesterone levels. And you can also see natural declines in testosterone, but it declines more gradually as we age versus menopause. You see much more of like a going off the cliff effect. And symptoms are really similar to perimenopause, just a continuation, except for the cycles are no longer there, but hot
you
flashes,
still have all the other
sweats.
annoying symptoms.
And it just depends on it depends on the woman too, how long the symptoms will last, how debilitating they are. Some women have really easy transitions, and some women it's really debilitating. And so that's where we can treat this though, and we really should.
Yeah, I'd love to get into this. So what can we do as we're starting to kind of embark on these hormonal changes? You know, there's a lot of talk around, bioidentical hormone replacement therapy. What's kind of your take on that, and what are some things that we can do to support our body?
Yeah, if we want to go into semantics again, I think bioidentical is a little bit of a marketing term, but I get its utility for sure. So bioidentical, what it's intended to be is it's identical to your body. However, all of the hormones that we use, all of them, compounded versions, commercial versions, they're not identical to your body. They're all slightly different, and they're all synthetic or semi-synthetic, I should say, meaning that they go through and they're manufactured and they're slightly changed. And that's important because of shelf stability and how they interact. We want them to be like that. And so I think the term bioidentical came about more from the compounding industry in a way to get people to buy things from them, to be totally honest. And I think it's really important for women to know that you can get hormones that are similar to the hormones your body produces. So if you want to call them bioidentical, biosimilar, but you can get them from a commercially available pharmacy like CVS and Walgreens, and your insurance can pay for them, and they're much cheaper than compounding pharmacies.
And there's really not that big of a difference, it sounds like.
There's not a difference in terms of the molecule that's used. There can be differences in terms of administration. So a lot of the times for compounding pharmacies, they're going to be using like estradiol creams. And in my mind, they're very messy and they're like hard to apply and like they get on your hands and you gotta wash it. Versus I start women off with a patch. And it's just like clean.
Seems a lot easier.
It's so much easier. And your insurance is paying for it, or should be. So I actually will always use the commercially available ones. Compounding pharmacies are great when we need a really fine-tuned dose adjustment that's not available commercially, or if somebody has an allergy to something, let's say in the patch or something that we have to avoid. But for majority of women, commercially available hormones is where we start.
Okay. And then at what stage during perimenopause should you start kind of incorporating some of this hormone replacement therapy if you're going to go that route?
Yeah, when you're symptomatic. Okay. So when you're noticing shifts, that's when we want to start to look at, okay, should we start hormone replacement therapy? We know that earlier use of hormones is better than waiting. So for outcomes, we see better results for women who start earlier. Does this mean starting at 35? Absolutely not. That's not what we want. But appropriately timed hormones can be really beneficial in how a woman, number one, goes through either very symptomatic or asymptomatic or with reduced symptoms. And then also looking at her bone mineral density and preserving that, because estrogen levels are going to be fluctuating during perimenopause and declining. So we want to make sure that that's on board as well. Same with vaginal atrophy. You don't want to wait to the vaginal tissues. Vaginal. New word. I've done that before. The vaginal tissues have atrophied and changed. You want to protect that tissue just when it starts to get dry. Like when you experience, okay, sex is now painful, or I'm noticing dryness down there that I've never noticed before. Like that's when we want to treat it. We don't want to wait till the actual skin has atrophied. Not all women will go on hormone replacement therapy. There are contraindications, and for some women it's going to be safer. For some women it might not make sense with their history and things like that. But having the discussion with your doctor is important. Okay.
And then, so what if your symptoms are subtle, right? Like what if you're just starting to get into perimenopause? You're like, hey, it's kind of subtle. Like, do I go on hormone replacement therapy just yet, or do I wait till things get worse? But then, as you're mentioning, that might be too late to kind of start kicking in, right? So how do you kind of walk that fine line of deciding when someone's ready and when someone should wait?
Yeah, and this is where the patient-doctor relationship comes in, where it is all about risk-benefit ratio in my mind. And that's going to be a one-on-one conversation with you and your doctor. But have the conversation earlier versus later, because you may want to think about it. You may want to do some research, and you do have time. So when we're talking about hormone replacement therapy, we want to avoid it when it's been greater than 10 years after menopause. It's not a complete contraindication, but definitely starting earlier has more benefits and potentially less risks as well. So I tell women, like, go as the first time you experience symptoms, or when you're wondering about it, even if you don't have symptoms, just have the conversation. Know what are the risks, what are the benefits, and start to educate yourself on it so that you can make a decision that's really rooted in evidence and understanding your family history, your personal history, and everything like that.
Absolutely. And then, so how long should you stay on hormones? So if you do decide to go down the hormone replacement therapy, is it something that you just take once you're kind of through the hormonal transition, or do you stay on it after menopause as well, just to make sure that things are staying balanced?
Yeah. And this is changing, I think. So we used to say, in terms of the guidelines, that you stop hormones 10 years after menopause, and it doesn't look like that's necessarily going to be the case anymore. And I definitely have women that are on it longer than 10 years post-menopause. So this is definitely, talk to your doctor about it, especially when we talk about low-dose vaginal estrogen, where you can be on low-dose vaginal estrogen your entire life. So just individual, talk to your doctor and see what's right for you. And we're looking at quality of life, right? And it's an individual decision where, one woman may not feel like she's herself at all without these hormones, versus one woman might not feel any different. And so that's going to look different for each of those women.
Absolutely. Awesome. And then, so let's talk about some of the changes that happen with your brain too. So I know brain fog can start to be something that comes on, right, as you're managing your hormones and kind of transitioning through this phase. So what are some things that you can do to support your brain in perimenopause?
Yeah, women can report brain fog, memory changes, cognitive changes, and they seem to be transient during that transition, meaning that when hormones start to shift, they start to experience those, and then they will improve on their own, even without treatment, is what we think. Estrogen is thought to be protective for the brain, but the social media space that says that everybody on the planet should be on estrogen because it's going to prevent dementia, that's like not the whole story. There's going to be, there's studies that show the opposite. The bottom line is we need more research, and we need more research that's really clear on like what type of estrogen are they using it, how long, does the woman have a uterus, are they using progesterone, what type of progesterone, like there needs to just be more variables that are tested. What was your original question? I'm like, I went down a rabbit hole.
I can't remember anymore. Okay. We got sidetracked. It's okay. We can move on. So what are some, it was about brain. Like what can you do to kind of preserve your brain during menopause? That was the question.
Got it. Yeah. Yeah. I mean,
maybe we're struggling with some brain fog today.
Yeah. And so, empirically, estrogen can help women with that sometimes. So if you go on a hormone replacement therapy, potentially improvements there. It probably is going to improve on its own as well. Stress reduction, we know, is going to be a factor there.
All the things you should be doing for everyday health, right?
Exercise, routine, exactly. The foundation, sleep, like making sure you're sleeping. One of the things that you have to think about if you experience like brain fog or memory changes during this transition is how are you sleeping? Are your hot flashes impairing your ability to sleep? Because treating the hot flashes and then sleeping well may improve the brain function too. So is this secondary? Is this a primary issue? But regardless, looking at all the factors.
Yeah, that was going to be my next question. So things that we can do to like improve the sleep, because it sounds like sleep is one of the first things that kind of goes haywire as well, right? Whether, like you said, it's from the hot flashes or it's just from other things going on. So what do you recommend for women to try to kind of prioritize and fix their sleep to optimize that so that they're feeling better overall?
Yeah, and it depends if we really think it's due to hormonal shifts, because progesterone can be helpful for sleep for women. So we may use some progesterone at night. If we notice that it came after a really stressful bout, then we're dealing with that separately. Cognitive behavioral therapy for insomnia, even just the basics of that can help almost everybody with
What is that
sleep.
exactly?
This is like one of the least talked about things that I think is a gold mine, because it helps like 9.5 out of 10 people with sleep issues. Okay.
Yeah, I'm interested because I have some sleep issues too.
Oh my goodness. I wish I knew about it years ago, but it's been a game changer for my patients, and I've gone through periods of insomnia myself. And CBTI is basically changing our behaviors around sleep and implementing a few strategies that we have to improve sleep quality. One of the keynotes of it is actually sleep restriction, which is the opposite of what we would think. If you're not sleeping well, why would you restrict your sleep? But what ends up happening is if you restrict your sleep, it increases your sleep drive, which is that power to make you sleepy. We have a couple different forces that we talk about in sleep therapy. One of them is sleep drive, which is like if you have a really high sleep drive, you want to fall asleep. You're exhausted. And then you also have activation. If you have really high activation, that can mean you're anxious, you're wired. And so with sleep therapy, we want to reduce activation, increase sleep drive. And one of the ways we increase sleep drive is sleep restriction, is actually shorten the window that we're allowing you to sleep to increase that sleep drive. And the purpose of that is to almost regain confidence in your body's ability to sleep throughout the night without waking up, and just reinforcing that circadian rhythm. You don't want to sleep restrict forever, because then you're just sleep deprived.
Yeah, exactly. I was going to say it can go down a dangerous path, right?
This is a tool that we use temporarily, with a clinician who's monitoring you. And if you're doing one thing for your sleep right now, wake up at the same time every single day. So you don't want your wake up time to shift. You want your bedtime to shift. And we'll actually shift the bedtime later and later until sleep gets really good, and then pull it back earlier and earlier. But that's a whole other podcast.
Yeah, I know that. We'll have to do a whole other episode on that. So let's talk about some of the other hormones. So we've talked about, estrogen, progesterone, testosterone, but we still have, other hormones going on in our body, like cortisol, that's probably affected during perimenopause, and blood sugar, maintaining that. What are some ways to manage kind of the other hormones, and are they affected as you're in perimenopause?
Yeah, they're not affected. Okay. So with perimenopause, you're really looking at, and I'm a naturopathic doctor, so I'm looking at the whole body, but cortisol should not be affected in perimenopause. Can you experience more stress in perimenopause? Absolutely. Yep. If you're not sleeping and you have hot flashes and you have these hormonal changes that are causing mood disruptions, can you be more stressed? Absolutely. But it's not due to perimenopause directly causing cortisol shifts. Gotcha. It's due to the fact that you're human, and if you put any
stressed out.
if you put any human through that, it would be stressful, right?
Yep.
We're not really thinking about cortisol changes during this time, with the exception of course, if you're stressed, we want to deal with stress.
Yep. Okay. Awesome. And then blood sugar and all that stays pretty maintained unless you've got other things going on, right?
Yeah, same thing. You're not going to have direct effects there. And this is where, social media, there's a lot of noise saying, women's cortisol is high and it's causing belly fat. And that's what you need to treat in perimenopause. And I'd just totally label it BS. You're going through hormonal shifts. They can be very stressful, and we still want to do things for the stress, but you're going down like a mechanistic approach that is overcomplicating an already complicated thing. So it just becomes unnecessary. When your body reduces its estrogen level, what you can experience is shifts in body fat redistribution. So estrogen helps to make sure that we're storing most of our fat around our hips, butt, and thighs, which is a reduced risk for cardiovascular disease compared to if you were to store that fat around the midsection. And when estrogen levels start to decrease, we can see increases in storage of fat around the midsection. And it's a really common complaint from women during this transition is, I don't remember this being here. And so that's a definite thing that can happen. But the change in terms of your hormones does not cause weight gain. I just did an Instagram reel about this. Your metabolism does not slow between the ages of 20 and 60, which is going to be the time where you go through perimenopause. Your metabolism maintains the same level unless you lose muscle mass. But it's the loss in muscle that's affecting your metabolism. It is not any hormonal shifts. It's not you aging. It's not being older. It's the fact that you lost muscle mass. Yeah, so if you can maintain or even gain muscle, your metabolism will not slow between those ages. Now, after the age of 60, it was a 2021 study that showed that you get really small decreases in metabolism. We're talking like 0.7%.
Wow, so not even enough to really make a difference.
Exactly. Yeah. Like if you're doing everything else, we shouldn't see these huge changes in body weight based on that.
Okay, good to know, because that is a common thing I hear a lot, right? Like people are like, oh, I'm in menopause, which is not even using the right terminology, really, right? And they're like, now I have all this like fat around my belly and I never used to have it and I can't get rid of it. So that seems to be a very common complaint I hear from people.
It's so common and it can be in part due to estrogen, just that redistribution, but your ability to lose fat, your ability to gain muscle is not affected by this menopausal transition. And it should be empowering for women. We should be like, okay, great. Like the odds are not completely against me.
It's like, because it's hard enough to focus on, because it's like overwhelming, right? Like you said, like there's a lot of misinformation about doing like the cortisol and blood sugar and all this stuff, but it doesn't sound like you have to worry about it. You just need to focus on certain hormones and what's going on with your body there.
Exactly. Yeah. It's like simplifying things can make it so much easier, because I have women that come to me and they're like, and now I can't even do HIIT because of cortisol. And then I'm going to stress my body and I can't do this because of this. And I'm like, whoa, we are overcomplicating the system here.
Yeah.
You're going to exercise. We're going to focus on weight training and moving your body, and you're going to be okay. You're going to be okay, and you can lose weight. It doesn't have to be so complicated either.
Yeah, I feel like things have definitely gotten overcomplicated in the health world, right? And it's so easy with like Instagram seeing a reel of like, you have this, or people just self-diagnosing themselves with all these things just because they're in that age bracket or think that it's happening to them, and they may not even be dealing with it, right?
100%.
So, need to be aware of that for sure.
Yes.
And then, so what are your thoughts on using supplements that can help with balancing hormones, like using DIM if you're estrogen dominant and things like that? Are there certain supplements or herbs that can be supportive of you during menopause or perimenopause?
Yeah, this is, and I want to say one more thing about the weight loss thing. If you're going through all these symptoms, hot flashes, more depression, anxiety, irritability, it makes sense that it's harder to lose weight, right? Because you don't feel good. So I don't want to gaslight people where it's like, it doesn't matter, like you can do it kind of thing. Like understand that it can be a hard thing to go through. We have a lot of tools there, but I also want to make sure people feel seen in terms of it's not, it can be harder. In terms of the supplements for menopause, like perimenopause specifically, you're not in a supplement deficiency. You're in an estrogen deficiency mostly. Okay. So I mostly am like, if we can use hormones and you have symptoms, why wouldn't we just start with what you're actually missing? Same with like the wild yam creams that are there. use progesterone. Like if you're trying to get progesterone, we've studied it. We know exactly what's in it. We know the dosage. I would just use the progesterone versus the wild yam creams. Black cohosh, will be used in perimenopause sometimes. I'm using estrogen when it's indicated. Just go to the thing that we know and it's worked if there's no contraindications. Yep. Now, if there's contraindications, then we can get more creative, but make sure you're using really good quality and that it actually has evidence to support it. And, there's other things like cognitive behavioral therapy that you can use, non-hormonal options that you can use for some of these as well. But I'm not a huge perimenopausal supplement person.
Gotcha. Okay, awesome. And then what are your thoughts? There's a big trend now with microdosing GLP-1s during menopause or perimenopause as well. What are your thoughts on using that as a tool to help with some of the inflammation and some of the hormonal balancing?
This is more Wild West stuff. Like there's literally
it is Wild West, isn't it?
There's no we don't have research studies on it, so you're kind of just like guessing, and you're using a pharmaceutical. So I don't use it in my practice for that reason. And there have been studies on dosing. So in order for a medication to get approved, it has to go through certain phases of research. And one of the phases of research is to look at efficacy of dosing and dosing safety. And so they are trying different doses, including lower doses than what you're seeing. And the reason why those doses didn't come and get FDA approved for the treatment is because they weren't effective. Otherwise, you'd see the dosage
much lower
because it would be effective. So we know if you're trying to lose weight, using less than the dose that's effective didn't show weight loss when compared to placebo. So are you having a placebo effect of it? Very possibly. And if you're using it off label for like lowering inflammation or things that like maybe, then I'd say, okay, you're rolling the dice. Maybe you're getting a benefit. We have no research to support it, but there's a potential because we are seeing these things have effects on, things other than weight loss. It's just not a go-to for me because in my mind it is like gambling. Like you don't really know
what someone's going to react
and you
with
have to be careful in terms of most people are going to compounding pharmacies for these micro doses, and that I am not a fan of. Like hands down, would not let my mother, would not let my siblings do a compounded GLP-1, and it's for ethical reasons as well as for safety reasons in my mind. There's just no reason to do that. So if you are taking a microdose of a GLP-1 right now, you could just switch to an Eli Lilly brand. And I think that's just going to be a safer option. But again, I'm not condoning the microdosing just because I don't think that there's enough evidence necessarily to support it. But I'm interested in the research as it comes out.
It's interesting for sure. And like all the other kind of conditions and things that it's helping with too, I think is really exciting too, not just using it for weight loss.
Yeah. And I'm so open-minded to that. Like I'm not going to be the person that's like, oh, I was wrong. It's like, I'm not wrong. I'm just saying we don't have the evidence yet and we could, and then I'll be really excited to use it. And if there's somebody that's really struggling with something and we've tried everything for them, would I potentially do something off label? Of course, like most doctors would say, of course.
That's right. Yeah. Give it a shot. And then, so I want to talk a little bit about movement and exercise. So you mentioned strength training is really good to kind of keep some of that muscle mass on you as you're going through perimenopause. What are some other workouts or exercises that can be really beneficial for women as they're aging?
Yeah, and it doesn't change really for women during different periods of their life in my mind. So women in their 20s, 30s, 40s, 50s, 60s, 70s, 80s, I'm going to recommend the same thing. And that's going to be resistance training is so important. It's so, so important, especially for... No, it's important for everybody. It's not especially. It's important for everybody, men, women, across the board. We need muscle on our bodies. Sarcopenia is an issue, whether you're normal body weight or low body weight, and that's just low muscle mass. Even people who are overweight can have low muscle mass. And we know that sarcopenia has a big link to osteoporosis. And when you're talking about women's health, you can't not talk about osteoporosis. Then if we look at the top 3 leading causes of death for women, number 1 is heart disease. And we know that resistance training and cardiovascular training are going to reduce your risk for heart disease. And then number 2 is going to be cancer. And if you have an ample amount of muscle on your body, not only does the activity of gaining that muscle, the resistance training and the cardiovascular training, reduce your risk for most types of cancers, but I almost think of your muscle is like your retirement account. Mm-hmm. It's like a bank account. It's like a savings account that you have in case of a rainy day. And we don't know how to fully prevent cancer yet. We just don't know everything about it. And when somebody goes through cancer treatment, one of the things that we're really concerned about is sarcopenia. It's weight loss, muscle loss, because there's so many health effects that can result from sarcopenia. Your risk of death increases with sarcopenia. If you get sick, your risk increases with sarcopenia. There's longer hospital stays with sarcopenia. And so you're really almost like putting money in that savings bank with the more muscle you put on your body. Now, if you're like a crazy bodybuilder, there's a limit that we don't get any additional return. But for most people,
we're far from bodybuilder, right?
Yeah, most people need more muscle on their body, and we want functional muscle. So it's really the strength that's even more important than the muscle mass that's there. But we should go through some of the stats around osteoporosis, because it makes it really evident why estrogen is really important, because estrogen is very protective to your bones, but also why your muscle is really important. Because if you have adequate muscle on your body, your risk for osteoporosis drops dramatically, and vice versa. If you're sarcopenic, you have a much higher risk for osteoporosis. And so if you're 70 years old and you're a woman and you fracture your hip, which is one of the main concerns of osteoporosis, you have about a 5% chance of death within 2 years after fracturing that hip. So that's like 1 in 20 women will die within 2 years of a hip fracture at the age of 70. That's crazy. At the age of 80, that number goes up to 11% of women will die within 2 years if they're 80 years old when they fracture a hip. That's 1 in 10 women. And then at the age of 90, it's 26% of women will die within 2 years of a hip fracture at the age of 90. That's 1 in 4 women. If we had 2 other women here and we were 90 years old, that's a really high number. And so I get really passionate about it because I didn't think about my bone health when I was younger. And if you're listening to this podcast and if you have a daughter or a son, your osteoporosis is a childhood disease. And what I mean by that is your bones are going to reach peak bone density as a young adult. And that's all formed during childhood nutrition, childhood exercise. Can we do things about it in our older years? We absolutely can, and we should. But we need to be thinking about it our entire lives, not just when we become older.
Then it's too late.
Yeah.
Yep. Amazing. Well, thank you so much. This has been so informative. All this information on hormones. I certainly learned a lot.
Good.
So if people want to reach out to you and find you and learn more, how can they reach you?
Yeah, my website is modernmed.com, and there's no E in modern, modrnmed.com. My Instagram, I put up a ton of free content there. It's at dr.marypardee. And then our practice is Instagram at modernmed as well.
Amazing. And we'll link to everything in the show notes as well. Thank you so much.
Thank you.